We are going to start the session with a panel discussion, and we have termed the panel discussion topics is real life challenges. So when there is a challenge, there is a solution. In the discussion, we are looking for the solution. I'm Dr. AFM Kamal Uddin, the Scientific Secretary of Oncology Club. Will be moderating the session, and this will be a quite interesting session. We have 6 panelists. We have Dr. Sudeep Gupta, who is the Director of ACTREC and a Professor of Medical Oncology in Tata Memorial Hospital. We have Dr. K. Govind Babu, very renowned medical oncologist, also President of Indian Society of Medical Oncology and Pediatric Oncology. We have Dr. John Conybeare, who is a consultant radiation oncologist from UK. We have Dr. Ismail Jatoi, who is a Professor of Surgical Oncology. In surgery in San Antonio, and we have Dr. Jaya Ghosh, who is a Professor of Medical Oncology from Tata Memorial Hospital, and last but not the least, we have Dr. Giles Kanik, who is the Surgical Head of Wickham Hospital for Breast Cancer Unit. And welcome to all of you, and some of you are with us for last few days, and Dr. Sudeep Gupta and Dr. Giles is first today with us. We hope we will have an interesting session. So we have designed it that we will be having 5 topics, and we will ask some of our colleagues to make a small presentation on each topic. And after the presentation, we will discuss to make some way out of this solution. So starting with the first presenter will be Dr. Ali Nafisa, who is an Associate Professor of Surgery, and she will be making her presentation on breast surgery without axillary lymph node dissection. How to proceed, Dr. Ali Nafisa.
Thank you, sir. Respected international faculties and national faculties and my dear learned audience, Assalamu alaikum. I am Dr. Ali Nafisa, going to present my today's topic on breast surgery without axillary lymph node dissection, how to proceed. We do axillary surgery to stage the axilla. It gives us the prognosis and help to plan the appropriate adjuvant therapy. Removal of positive node reduces chance of regional recurrence. Removing of axillary lymph node does not significantly affect the survival. Nodal status is most important prognostic factor. Axillary lymph node dissection have few life-changing complication like 28% risk of lymphedema. This is why the need of concept of minimally invasive approach like SNB comes forward for clinically and ultrasonologically axillary negative axilla. The sentinel node is nodes which receives lymphatic drainage directly from the primary tumor. During surgery, we do axillary lymph node biopsy. When it reveals negative, indicates the rest of axilla is negative for metastasis. So no need of surgery, more surgery. When the axillary lymph node is positive, we have to treat the axilla further by radiotherapy or axillary clearance. If sentinel lymph node biopsy positive, we are still clearing the axilla for post-NECT patient when tumor size is more than T2 and when in lymph node 2 positive. This option might change in future. Clinically node negative but sentinel lymph node biopsy positive, the treatment paradigm has shifted toward de-escalation of further axillary surgery. 2 or fewer positive sentinel lymph node, the standard of practice has shifted from axillary clearance as a result of Z11. Let's have a look at 10 years outcome of 3 randomized control trial. Z11 trial shows more than 10 years outcome data, similar disease-free survival and overall survival to axillary clearance group and no axillary clearance group for 1 to 2 sentinel lymph node positive. Similar data shows on IBCSG 2301 trial. Another trial, Amaros trial, which also published the 10 years outcome data for axillary radiotherapy and axillary lymph node biopsy, axillary clearance, the overall disease-free overall survival and disease-free survival benefit almost same. The SOUND trial takes one step forward, the Z11, to determine if axillary staging could even be omitted in selected cases with invasive breast cancer for T1N0 patient. All trials shows SMB positive patient can avoid further axillary clearance, so frozen facility is not mandatory for doing sentinel lymph node biopsy. We can avoid axillary lymph node dissection by offering radiotherapy if SNB positive to avoid lymphedema, which affect quality of life of cancer patient. Are we brave enough to do only breast surgery for post-NEC patient and avoiding axillary surgery? Are we brave enough to treat axilla with radiotherapy and only? Still, are we brave enough to avoid radiotherapy which patients are suitable for a prime 2 trial? Thanks for listening.
After all this trial, we know that we have two conclusive trials. One is Z11 and another is MROs. But the problem with Z11 is it's a good result, but we cannot accept it because we have found that there are some flaws. But in San Antonio 2018, this MROs trial has made a good conclusion. Now I want to ask John, as a radiation oncologist, what's your take? Are you convinced that you want to give radiation against surgery in this type of situation, early breast cancer? John.
So yeah, I personally think you can replace surgery with radiotherapy, but I think when you do, you really have to be confident that what you're defining as your radiotherapy volume to treat will encompass entirely the nodal volume. And I think, as you know, historically we are very confident to use field-based radiotherapy for covering the axilla. But certainly in my practice, as I've come to begin to contour more patients, what becomes clear that depending on whether you use the RTOG or ESMO atlases for defining your lymph node levels, that the volume that you treat sometimes in fact is bigger than what you would typically see if you applied a field border-based planning approach. So it's a learning curve, and I think it's important that you take your time when you learn on that curve, because what you don't want to do is to undertreat a patient and as a consequence have them relapse in that local area.
Thanks, John. So what we understand that John is ready to treat the patient with radiation in this type of situation based on this MROs trial. Now, coming back to the surgeons, Dr. Giles, if a lumpectomy is done, not knowing that it was a malignancy, but finally it came out to be a malignancy and they found there's a clear margin, and clinically there is no node, radiologically there is no node, will you go for a SNB or you will ask the patient to go away? I mean, it's early stage, very early, say 1.5 centimeter, ERPR positive, grade 1, very low risk, 50 years lady. Will you go for SNB, Dr. Giles?
Yes, at the moment, there's no evidence that we should avoid an SMB. It will affect treatment. And of course, in the UK, we nearly always have a diagnosis from a core biopsy, but I understand that isn't the case everywhere in the world. But at the moment, I mean, we do get that situation where we'll do a wide local excision sometimes for what we think is DCIS, and we will find invasion. And even if it's only a few millimeters of invasion, we will discuss with that patient whether or not to do an SNB. Of course, if it's a very small cancer, if it's 2 millimeters or something very small, then we would discuss the pros and cons and say that it's likely to be a negative node. And so for that patient, we might say it's a very low risk and she will avoid it. But if it's anything over about a centimeter or so, our MDT would advise going to do the staging sentinel node biopsy, because it's not going to make a difference to survival, and you'll see that from my talk. I will drum that point home, but it will affect regional recurrence, and or potentially could, if for those women with positive nodes, we will be leaving those positive nodes in there. We may just then end up treating the breast with radiotherapy, assuming the nodes are negative, and of course we might not give them chemotherapy if the node is if we assume the node is negative when it's positive. So at the moment, there's no data to say that we can avoid sentinel node biopsy in those patients, although there is this trial, which was alluded to, the SOUND trial, for patients like this, where we're randomizing them to sentinel node biopsy or no sentinel node biopsy. So the answer will become available in due course. So I can't hear you.
Sorry. So I'm coming to Dr. Ismail because he's a senior person. Say we are in a country where sentinel node biopsy is not everywhere possible. It is not available. Facility is not available. So in that situation, what will be your take? Will you be suggesting accelerated sampling? Dr. Ismail.
Just to kind of, I'll kind of give my little background and take on this thing. As has been mentioned, there are a couple of trials now ongoing looking at the option of avoiding axillary surgery altogether. There's a SOUND trial, there's a Dutch trial, the BOOG trial, and there's ENSEMA. So there are 3 European trials looking at the option of avoiding axillary surgery, including avoiding sentinel lymph node biopsy altogether in a large subset of patients. But these are randomized trials. We don't have the results of those trials yet. So those trials will be practice changing. If they show that there's no advantage to sentinel lymph node biopsy in clinically node negative patients, again, I emphasize in clinically node negative patients, then this will be a very dramatic change in the way we do things. But again, we don't have the results of those trials yet, so we're not really ready to move forward and take that step, avoiding axillary surgery. The other thing is, we've known for many years that you can treat the axilla with either surgery or radiation, clinically node negative patients who have no palpable disease, nothing on imaging, no tissue diagnosis showing disease in the axilla. We've known for many years we can treat those patients with either surgery or radiation. This goes back to NSABP4 in the King's Cambridge trial, which showed that basically surgery and radiation therapy of the axilla were equivalent in terms of local control. They both brought the risk of recurrence down to acceptable levels. The advantage of surgery was staging. And now we've known from the AMROS trial that there's better quality of life with radiation when compared to surgery. You have less lymphedema. So surgery and radiation are alternatives in terms of managing the axilla. The other issue I'll bring up is, these trials have all been conducted in Western countries where the burden of axillary disease is low. Many of these, in most cases, these patients had screen detected cancers. In India and Bangladesh, this is a very different situation. You don't have, widespread use of screening mammography, and the burden of axillary disease is oftentimes higher. So again, in clinically node negative patients, I think the choice is surgery versus sentinel lymph node biopsy. In terms of axillary sampling, that's, we don't really do that here in San Antonio. It's either sentinel lymph node biopsy and then manage the sentinel lymph node, depending on whether it's positive or negative accordingly. Or if the patient's clinically node positive, we would recommend axillary dissection if the patient is clinically node positive. But in clinically node negative patients, we would generally recommend sentinel lymph node biopsy. So axillary sampling, I know it's done. We don't do that and it's not as routinely done here in the United States as it is perhaps in India. The problem with actually sampling, I think, is the question of are you taking out the correct nodes? And if it's done properly, I suppose it's an alternative. If the sentinel lymph node is included in that sampling. But on the other hand, if you're away from the sentinel lymph nodes and you're not sampling the sentinel lymph nodes, you potentially could miss disease and leave disease behind. So the other point to bring up is that there's data showing that local recurrences do matter in terms of mortality. 4 local recurrences lead to 1 extra breast cancer death over a 15-year period. That comes from the meta-analysis that was published in Lancet many years ago. So local recurrences could potentially have a bearing on mortality, and we have to be careful in terms of, especially in younger patients where there's a long lifespan. We have to be careful in terms of reducing the risk of local recurrences, because we realize that may ultimately translate to mortality decrement. So in the answer to your question is actually sampling, is it an alternative to sentinel lymph node biopsy? We don't have good evidence, in terms of randomized trial evidence that actually sampling equals sentinel lymph node biopsy. I know it's done, and if the sentinel lymph node is included in the sampling, I think it would be an acceptable alternative.
Okay, Ismail, I understand. So I am going to Dr. Sudeep Gupta. He is not a surgeon, but I'm sure in his practical life, every day he is facing this type of situation where we are getting patients having surgery not adequately done or axillary surgery is not done. Sir, how you people are handling this? Dr. Sudeep Gupta.
So thank you, Dr. Kamaluddin, and hello to everyone else. I would like to support what Dr. Jatoi just said, and I will just like to reiterate two further points. One is that, as he correctly pointed out, most patients in India, Bangladesh, and many similar countries do not have screen detected cancers. And so they are not inherently lower risk set of cancers, but they are clinically palpable high risk cancers, more often triple negative, and more often with a higher pretest probability of having axillary involvement. So just transplanting and transporting the results of Western studies into our population may not be completely appropriate. And so therefore, before we do away with the idea of axillary surgery altogether, I think we have to be very careful. At our hospital, Tata Memorial Center, we do perform axillary sampling, and it has been performed by our surgical colleagues for a long, long time. And they have a precisely defined anatomical boundary of what they take out. And very recently, they published in the JCO Global Oncology showing that in the post-neoadjuvant situation with a clinically node-negative axilla, the false negative rate of axillary sampling was actually lower than that of sentinel lymph node biopsy. But as Dr. Jatoi also correctly pointed out, there is no level 1 evidence. There isn't a randomized trial. But if there is a center that has experience with axillary sampling, then it can go ahead and practice axillary sampling.
Thank you, sir. I think we will move to our next topic because what we understand that yes, axilla is a very important portion for breast cancer management and we should not ignore it. There are some opportunities for early stage breast cancer to do SNB, and if it is negative, we can go away with radiotherapy, we can avoid surgery. But as Dr. Ismail Jatoi and Dr. Sudeep Gupta was mentioning, we are in a high burden area where this type of situation is not very common. But if there is, definitely we should give the chance. Otherwise, we will go for classical surgery, axillary dissection, not to take any risk because we need a good care. Okay, now we go to our next topics. Contralateral axillary nodal metastasis in breast carcinoma, how to treat. Presenter is Dr. Asma Siddiqa, who is the Assistant Professor of Radiation Oncology Department of National Institute of Cancer Research and Hospital. She will be talking on her topics. Dr. Asma Siddiqa.
Thank you, Oncology Club, for inviting me to be here. Respected faculties and learned audience, Assalamu alaikum and a very good evening to you all. I am Dr. Asma Siddiqa. I will talk on contralateral axillary nodal metastasis in breast carcinoma. Outset of my presentation, I would like to draw a scenario in front of you all. A 45-year-old premenopausal lady with no history of comorbidity and no personal history of cancer presented with a left breast mass in upper and outer quadrant of the breast. Ultrasonogram and mammography are done, and it reveals a mass and significant enlargement in the left axillary lymph node. Core biopsy was done from the left breast mass, and it showed infiltrating duct cell carcinoma grade 2, ER positive, ER negative, PR negative, HER2 positive. Other investigation, liver investigation was done, and it was clinically T2N1 M0. She underwent left MRM with axillary dissection, and as patient desired to do MRM, and pathological staging was similar to clinical staging. But after surgery, patient noticed a lump in the right axilla, and FNC showed metastatic duct cell carcinoma. Now, the question arises in mind, is this a roconogenal disease or a metastatic disease? Now, let's some things, what we know, some facts about the contralateral axillary nodal metastasis. This is an uncommon, confusing clinical scenario. Incidence is 1.926%. And there is no strong evidence, as there is no RCT regarding the treatment recommendation. It may be synchronous or metachronous. Metachronous are more common, and it usually occurs 3 to 5 years after initial completion of initial treatment. It usually associated with aggressive variety of breast cancer that is in high grade T3, T4 lesion, skin involvement, and ER positive, HER2 negative, ER negative, PR negative, HER2 positive disease. Pathophysiology is mostly uncertain, but there is 3 potential sources of contralateral spread. Contralateral spread from the original breast cancer occur due to the altered lymphatics. And these altered lymphatics are occur due to some surgery, previous radiation, or there is aberrant lymphatic in some patients over the chest, which causes contralateral spread from initial breast cancer. There may be occult primary in contralateral base, which cannot identify even in MRI. Third thought is that metastasis can done from extramammary site. Extensive metastatic survey is required. MRI PET CT also useful for identifying the metastatic foci. According to AJCC staging manual, 8th edition, it is designated as a M1 disease, that is stage 4 disease. Treatment recommendation is not straightforward, as there is no RCT. This is a paper, this is a case review and a review of the literature which published in Journal of Breast Disease in 2013, where it shown a 52-year lady who was treated with lymph node dissection, this contralateral lymph node dissection, radiation therapy, chemotherapy, and hormonal therapy. Now, 13 months after second surgery, the patient is alive without any evidence of breast cancer recurrence or metastasis. They informed this case review, they recommended treatment should done with curative intent, which has a good overall survival. This is again a case scenario presented in the breast journal, where 7 patients were recruited this case scenario. Some 14% has surgical management of the contralateral axillary metastasis done in 14% patient. In 71% opposite axillary lymph node dissection is done. Adjuvant treatment systemic, that is the systemic chemotherapy and hormonal therapy was given to 100% patient. Systemic chemotherapy is given to 100% patient, and hormonal therapy were received in 14% patient. After 35 months of observation, 3 patients were alive without disease, 2 were alive with disease, and 2 had died. And they suggest that surgical treatment, due to surgical treatment, there were no axillary recurrence. So the recommendation is surgical treatment should be considered for local control and which possibly improve the relapse-free survival. This is another study which included 28 patients, and treatment modalities were the axillary lymph node dissection, mastectomy, opposite side mastectomy, radiation therapy, and chemotherapy, and plasma targeted therapy who were HER2 positive. After 20 months of follow-up, 25 patients, that is most of the patients, progression has disease progression with a median progression-free survival of 10 months. They reported this. They reported that this treatment has a poor prognosis and most likely to be occur due to distal metastasis.
1 minute more.
So treatment recommendation regarding several publications have questions regarding treatment. Some favor multimodality treatment, that is surgery, radiotherapy, and systemic therapy. Others suggest limited therapeutic intervention. Regarding the prognosis, a study that is included 47 patients. Median follow-up was 5.4 years. All the patients were treated with surgical and systemic therapy with a curative intent, and there was estimated overall survival 5 years for 72%. It indicates, it concluded that outcome is better compared to stage 4 disease. Thank you all.
Thank you, Dr. Asma. So now we understand that this is a situation where we have no RCT. In the era of evidence-based medicine, we have no RCT. the first question comes in mind that whether we should treat the patient with curative intent or palliative intent. So I again start with the surgeon, Dr. Giles. So would you go for a surgery of this type of patient? If it is a surgery, will you go for excision or axial lymph node dissection? Giles.
Yeah, so first of all, we would stage the patient to make sure there's no metastatic disease, because if there's metastatic disease, then the patient is not curable, and then it then depends on the burden of the axilla and the burden systemically. Because if they've got a liver full of disease and a chest full of disease, you're not going to achieve much by removing the lymph nodes. However, if the lymph nodes, if the staging CT is clear, then we would aim to cure by removing the contralateral nodes. Before we would do that, I would feel also happier just making sure that there isn't a contralateral primary, that this lady hasn't got bilateral disease, and we would do that with an MRI of the breast and mammograms and ultrasound. So we would absolutely make sure that we're not talking about bilateral disease. But this does happen. We know from sentinel node biopsies that sometimes, not very commonly, you'll inject one breast and the node will show up on the scan on the other axilla. So it does happen. So yes, if there's systemically clear and there's no contralateral primary, we would offer an axillary clearance.
So you will go for excision, not excision. Fine. So yeah. Now I'm moving to medical oncology. Dr. Jaya, are you there? So you had a patient with T2N1 disease, and you had a plan to give her some adjuvant chemotherapy. And then suddenly, before starting the adjuvant chemotherapy, this contralateral node showed up, and Dr. Giles has taken it out, and now it is positive. Will you change your plan on adjuvant chemotherapy, Jaya?
No, because I would, of course, as Dr. Giles already mentioned, we would treat her as an oligometastatic disease with curative intent if there is no disease elsewhere. And my plan of adjuvant chemotherapy would remain the same, because even if she had an ipsilateral node, we would have given her an anthracycline followed by a taxane-based regimen. And it would remain the same in this case also. We would give her anthracycline followed by taxanes.
So I can think that the story about chemo, in that case, if it is a hormone receptor positive, all the plan will be the same. I mean, this additional node is not going to change or any adjuvant plan. Either it is a chemo or hormone.
No, it's going to be the same. And only thing with hormone, of course, this is node positive. So otherwise also probably we would continue. Sorry, I forgot the age of the patient was. So we can consider extended hormone therapy for 5 to 10 years. That is the only other thing. But that would be irrespective of that additional node on the contralateral side. Because even if the ipsilateral is positive, we would consider. But the case becomes stronger if the opposite node is also positive. Then probably I would continue for 10 years of hormone therapy.
Thank you, Joya. So I'm coming to John. So John, you had a plan to treat this patient with radiation. It was a mastectomy done, but now there is a contralateral node. So what will be a change in your plan in radiation, John?
So again, as my two predecessors said, providing we've done, very detailed staging and we're absolutely certain that there's no signs of distant disease, and that there's correlation between the histopathological subtypes. So the contralateral disease is equivalent to what we found on the ipsilateral side. Proceed with the originally planned radiotherapy, but I've also, again, it depends how many lymph nodes come out on the axillary clearance. I think what would be potentially something for discussion amongst our NDT is, for instance, you did a contralateral axillary clearance and you found 5 out of 11 nodes positive.
Yeah, say it was 5 out of 11 positive. So we create a scenario.
Yeah, so in that case, I would treat the contralateral side SCF and probably include the whole breast as well. to make sure that we're not missing a burnt out microscopic tumor, you know. So I would treat them aggressively in the adjuvant setting.
So that was that point actually I wanted to bring it here, that there is no hard and fast recommendation how to treat this type of situation, but we need to assess the scenario. And the most important thing is that even HSCC 8th edition is considering it as a M1 stage 4 disease, but we have seen in many series the outcome of this type of patient is better than stage 4. So there is a good chance that if we can really hit the target properly by surgery, by chemotherapy, and by radiotherapy, maybe we make an overkill, but hopefully there is a chance that we are giving her a better cure. So why not? There is no right and wrong. But what John said, I will be with him. If it was a 5-node, maybe I will also cover the breast. But if it was only 1 node, maybe I will be thinking, shall I or shall I not? And I mean, as I said, there is no RCT, no level 1 evidence. But yes, this is the situation in our real life, and we need to manage it like this. But whatever we do, we need to think judiciously and also discuss with our patient about the limitation of this decision. So we move our next topics. So the next topic is surgery to the primary tumor in patients presenting with de novo metastatic breast cancer, to do or not to do. Our presenter is Dr. Hassan Shahriar Kollol, who is a promising surgical oncologist, assistant professor, and also doing his further fellowship program in surgical oncology, National Institute of Cancer Research and Hospital. Now I request Dr. Kollol to make his presentation.
Thank you, sir. Very good evening to all the participants and panelists from home and abroad. So today my topic is surgery of the primary tumor in patients presenting with de novo metastatic breast cancer, to do or not to do. So we all know that the prognosis of the localized breast cancer is very good in respect to treatment, and patient with metastatic disease, the result is a bit dismal, and 5-year survival is less than 30%. So what we can do for these patients who present with us with metastatic disease? So should we do surgery for this metastatic breast cancer? So we have 3 issues to discuss. So whether it would be curative or palliative, whether we should go for surgery in a metastatic breast setting in multiple site metastasis or oligomets. And if we go for surgery, whether it would be a mastectomy or lumpectomy. So if we go for the evidences, what is the basis of reservation on removal of the primary tumor in metastatic breast cancer? So contribute substantial to palliation, but not to survival of the patient, as there are some evidence that surgical stress releases growth factors which promote metastatic proliferation. And primary lesion is thought to inhibit angiogenesis in metastatic lesion. And then surgical injury enhances the expression of genes to promote breast cancer mets to the lung. And there are other evidences that removal of the primary tumor in breast cancer increases cancer cell presence in sentinel lymph nodes. So these experiments actually did not use breast cancer cells or clinically relevant endpoints such as disease-free survival or overall survival. So then why do we operate, or we try to operate? The role of removal of the primary tumor in metastatic breast cancer. So progression from primary tumor to metastasis, this is a much more dynamic and multidirectional process than once thought earlier. So factors released at the primary tumor stromal level facilitated distant metastatic proliferation, and metastatic lesions self-seed other sites as well as the primary breast tumor itself, which may link local control with controlling the distant recurrences. So and study, this is an animal study done on syngeneic bulbs mice, and they tried to see the effects of primary tumor resection on metastatic progression, overall tumor burden, and overall survival. And interestingly, they found that removal of the primary tumor significantly reduced the overall tumor burden compared to observation alone arm, which contribute for improved survival. Another thing is that radical nephrectomy in case of RCC improved survival of metastatic renal cell carcinoma, and the effect of improved local control with radiotherapy on improving overall survival. These studies also contribute to the thought that might be the primary tumor resection can help. So there are some retrospective studies on the outcome of the removal of the primary tumor in metastatic breast cancer setting. So these two studies, actually, they have seen 16,203 patients and 9,734 patients, among which 57.2% had surgery, and 3-year survival improved from 26% to 35%. And in this study, median survival improved from 21 months to 36 months. So there are other studies which showed that improved progression-free survival, improved survival in estrogen receptor positive patients only. And in this study, 3-year survival improved from 26.7% to 43.4%. These are very encouraging, no doubt. But there are other side as well. So these 3 studies, they have shown that no correlation between surgery and survival. And they have cited some selection bias as well, and improved survival confounded by stage migration and survival benefit associated with chemotherapy rather than surgery. So they did a meta-analysis. So this meta-analysis showed that improved survival with a hazard ratio of 0.69 with a p-value of less than 0.00001, so which is very good, and this is independent of the confounding factors and directly proportional to the exposure to systemic and radiotherapy, inversely correlated with estrogen receptor status.
1 minute more.
So there are some consensus meeting as well. So they found that oligometastatic breast cancer can do well in surgery in an appropriately selective subgroup of patients with young, good performance status and hormone positive and good response to systemic treatment. So there are some RCTs as well, but the RCT is done in Tata Memorial Hospital, and there's a Cochrane review of these 2 RCTs, 624 women, and breast surgery plus systemic therapy and systemic therapy alone. And the results were, they were uncertain that breast surgery improves the overall survival. So the implication of practice, it is not possible to make definitive conclusion, and until the ongoing clinical trials are finalized, the decision to perform breast surgery would be individualized and shared. These are the ongoing prospective clinical trials, and possibly after these trials we can conclude actually, but we can say till now it is an option. Definitely it should be individualized, and it is good results in oligometastatic setting. Thank you very much.
So thanks, Kamal. We understand that this is an area where still there is a debate because there is only 2 RCT. Tata was a negative trial, and the Turkish was criticized for their selection bias. So at this situation, I will ask Dr. Ismail. So what is your take? Are you a believer of doing surgery or not?
So I think the Tata trial, of course, when you compare the Tata and the Turkish trial, the Tata trial, I think gave us the more definitive answer that there's no advantage to surgery in the metastatic setting. The problem with the Turkish trial was that there's an imbalance. So there are more ER positive patients in the group that underwent surgery. So basically, there was an imbalance. What they should have done in the Turkish trial, which they didn't do, is stratify. They should have stratified patients according to ER, and that was not done. And so the Turkish trial came to the conclusion that in patients that have isolated metastasis of the bone, there may be an advantage to surgery, but I don't think you can really trust those results because of the imbalance and the stratification. But I think and also, by the way, Seema Khan here in the United States has undertaken a trial which also showed no advantage to surgery in the metastatic setting. So we've got 2 randomized trials that have shown no advantage, and I think there's a concern with the Turkish trial with regards to the fact that it wasn't stratified. There were about 125 patients in those trials, and when you have those small numbers, stratification should have been done. It wasn't done. So I think, if you were to ask me, I would say at this point the preponderance of evidence is that there's no benefit to surgery in the metastatic setting, based on data from randomized trials. Now, there is the quality of life issue, which is a separate issue. Now, in patients, for example, who present with metastatic disease, they have an ulcerated lesion, and there's concerns about the lesion getting bigger or whatever. We oftentimes do surgery with the concern being that, or with the intent being that we're improving quality of life in these patients. it's not done to improve mortality or reduce mortality, improve survival. It's done with the quality of life consideration in mind. But in answer to your question, is there evidence of benefit for survival? I would say no. And I'd say the most definitive trial seems to be the Tata trial, with Seema Khan's trial here in the United States also supporting that conclusion. I have questions about the Turkish trial, given the fact that it wasn't stratified.
Thanks, Ismail. I understand that till now we don't have enough evidence to support the surgery in metastatic setup. So now I'm coming to Dr. Govind Babu. So you have a patient, you have done a wonderful chemotherapy, maybe some targeted therapy. There is a wonderful complete response. So now the patient is eager to do a surgery. Are you interested to discuss with your surgeon colleagues to do some surgery there? Dr. Govind Babu.
Yeah, Kamal, thank you for asking me this. In fact, I will just quote one of a patient we had recently who underwent surgery. She was actually being treated for refractory anemia, and then a hematologist did a bone marrow and found metastatic disease. And then we realized that she had a breast lump. So she was presented with metastatic disease, and then I started her on chemotherapy. She was ER/PR positive, HER2 negative. So fortunately for her, she went into complete remission. But the bone marrow became negative, and PET scan wise, there was no disease anywhere else. The breast lump, unfortunately, started fungating. So that is when I had to get her to undergo surgery. So, even if it had not fungated, maybe I would have discussed with her about surgery, because she was keen on surgery, because she said, I have no disease elsewhere and I'm sitting with this lump in the breast and I want to have surgery. So this is not a common situation at all. This is one of the rare situations, but she has undergone surgery there. So in metastatic disease, like we heard, we don't have great evidence to support for local surgery, except for taking care of fungation, things like that. Otherwise, no surgery.
Thanks, Govind. Now I'm coming to Dr. Sudeep Gupta. If it is oligometastasis, so now the world is, last year Astro was very busy with oligometastasis. We are telling it is neither metastatic nor local, it is something in between, which is probably curative. So in your MDT, are you supporting surgery in oligometastasis? Dr. Sudeep Gupta.
Yeah, thank you very much, Dr. Kamaluddin. And I would completely support Dr. Jatoi and Dr. Govind Babu in saying that actually there is evidence against performing surgery in patients with metastatic disease. The correct statement is not that there is no evidence in favor of surgery. There is actually evidence against surgery. But, let me come to your question. In the Tata Memorial Center's randomized trial, patients with oligometastasis were excluded from the study. And our routine practice is to perform surgery for the local tumor in patients who have only limited metastatic disease. And I will also call your attention to the fact that there are variable definitions of oligometastatic disease, and different institutions and different societies define them differently. But whenever you have disease that is limited in metastatic intent, then it may be appropriate to perform surgery both for the local tumor and sometimes also for the metastatic disease. But those are very few patients, and there is absence, or at least absence of good evidence in that particular subset, and there you might perform surgery.
Thank you, Dr. Sudeep. Actually, as you mentioned, things are moving so fast. Say, Dr. Kamal was talking about the nephrectomy, but there are evidence that now they are telling that nephrectomy may not be offering some curative benefits. So after Carmina trial, this is now debatable. So things are not very static in oncology. Things are dynamic, and situation like this, where we don't have enough evidence, definite guideline, debatable, we should always be very cautious about taking a decision. But as we always talking, we should be always considering the fact that end of the day, we want a good service to the patient and good outcome. So now we are moving to our next topics. It's a very discussed topics in this region. Shorter duration of anti-HER2 therapy are now warranted in selected patients. Is it justified? Our presenter is Dr. Jahangir Alam, who is a medical oncologist. working in National Institute of Cancer Research and Hospital. Dr. Jahangir, would you please mind to start your presentation? Dr. Jahangir Alam.
Thank you, sir, and thank you, Oncology Club Bangladesh, and to give me this chance to say something in this international big platform.
Please share your screen.
Yes, sir.
If you want, we can share a screen for you.
I can.
Samir, share the screen for him.
I can, sir.
You can?
Yes, sir.
So,
This is not.
Samir, share the screen for him. Jahangir, you stop share. Let Samir share for you. Samir.
I have shared the screen.
Start. Yeah, the make a slideshow.
Yes, sir. Okay, welcome to you all in my session. Next slide. Shorter durations of anti-HER2 therapy. 1 year trastuzumab treatment should remain as the preferred treatment for early stage HER2 positive breast cancer. Shorter durations trastuzumab may be an alternative choice for patients with cardiac disease and at a lower risk of recurrence. Trastuzumab be given concurrent with adjuvant chemotherapy may serve as a standard of care alternative to sequential treatment. 1 year trastuzumab is correlated with higher risk of cardiotoxicity than short duration schedule. Next. In HERA trial, randomized three-arm multicentric comparison of 1 year and 2 years trastuzumab versus no trastuzumab in women who have completed chemotherapy. Next. In interpretation, there are 1 year versus 2 years Herceptin. Here, disease-free survival, no difference, hazard ratio 0.99 and p-value 0.86. And overall survival, also no difference. Here, hazard ratio 1.05 and p-value 0.63. Next. Another trial is non-inferiority trial. There are 6 versus 12 months of adjuvant trastuzumab for HER2 positive early breast cancer, Persifino, and 4-year disease-free survival results of a randomized phase 3 non-inferiority trial. Next. And another trial, a big trial, the SOUL trial, effect of adjuvant trastuzumab for a duration of 9 weeks versus 1 year with concomitant chemotherapy for early human epidermal growth factor receptor 2 positive breast cancer. Here, disease-free survival in 51 weeks, 82%, and 9 weeks, 76%. And distant disease-free survival in 51 weeks, 83%, and 9 weeks, 80%. And overall survival, 51 weeks, 87%, and 9 weeks, 81%. Next. That is, 9 weeks of trastuzumab may be as effective as 52 weeks in the adjuvant setting. No cardiac toxicity was observed in the trastuzumab treated patients. And tremendous economic implications also. Next. Another big trial, short HER trial, multicentric randomized phase 3 trial of 2 different adjuvant chemotherapy regimens plus 3 versus 12 months of trastuzumab in patients with HER2 positive breast cancer. And in the FAIR trial, 6 months versus 12 months adjuvant trastuzumab for patients with HER2 positive early breast cancer, a randomized phase 3 trial. Here, after 3.5 years follow-up, we failed to show that 6 months of treatment with trastuzumab was non-inferior to 12 months of trastuzumab, despite the higher rates of cardiac events, and 12 months of adjuvant trastuzumab should remain the standard of care. In my conclusion, the combination of trastuzumab and chemotherapy has notable risk of cardiac toxicity. Careful monitoring of cardiac function of a vital importance if trastuzumab is to be used in the adjuvant setting. But shorter duration of trastuzumab may be effective as 52 weeks in adjuvant setting in selective patients. Short duration of trastuzumab as less cardiac toxic and tremendous economic benefit also. Thank you for patience hearing.
Thank you, Jahangir. So now this is a burning issue. We know there were many efforts except pre-spawn trial. None of the trial could reach the target, but still we love to look for the window to go for 6 months against 12 months because it is money, because it is toxicity. So let me point out that in St. Gallen 2019, 100% didn't vote for 12 months. It was near about 89.8% recommended 12 months trastuzumab. And also, if you look at the ESMO guideline, they have said that we have some window to use 6 months. We can discuss the role of 6 months, which was recommended by ESMO early breast cancer and also in the COVID recommended. So I want to touch upon the 3 medical oncology colleagues. I start with Dr. Sudeep Gupta. What is your take, sir, in our region that can we start thinking of 6 months where there is an issue of money? The patient cannot afford. Shall we say no or give 6 months?
So thank you, Dr. Kamaluddin, for asking me this question. And I think very recently, only a couple of months ago, we published a meta-analysis of all these trials from Tata Memorial Center in JAMA Network Open. And this was actually an individual patient meta-analysis with extracted data and included about 12,000 patients in all. And I will send you the link to that publication after this discussion. And there actually we showed that when we combine all the studies together, actually non-inferiority was proven for shorter durations versus 1 year. Now there are 2 ways to look at it. By its very definition, 6 months or shorter durations cannot be more effective in terms of disease control compared to 12 months. The absolute difference in our meta-analysis in disease-free survival was about 1.7%, 5-year disease-free survival. So our take on this issue is that in patients who have favorable risk disease, for example, patients with small tumors, node-negative tumors with ER positivity, may actually, in such patients, 6 months of trastuzumab may suffice. And as was correctly pointed out, there is definitely a higher risk of cardiac toxicity with 1 year of trastuzumab compared to 6 months. Also, when there are economic considerations when patients cannot afford 1 year of treatment, in those scenarios, also we believe that 6 months or even 3 months of trastuzumab would be appropriate choices. But our meta-analysis does prove in overall that shorter durations are actually non-inferior to 1 year of trastuzumab.
Thank you. I'm coming to Dr. Govind. So it was on early. So when is a metastatic setup? So we know whatever we give, that is an addition. We are not going to offer her cure. And we don't have any answer that how long it will be. It is 1 year, maybe until disease progression. But somebody in a situation that she can afford 6 months. So can we put something? Something is better than nothing, or you say, no, don't waste your money and keep it for something future.
You're talking of adjuvant or metastatic now?
Metastatic. I'm talking now metastatic.
Oh, no. There's really no point in giving 6. If she can afford only 6, no point there. Definitely not. It's not like adjuvant that you can give a lower duration and still expect good results. No, not in metastatic.
So The message is that we can tailor it when in a selected patient of adjuvant, but in metastatic, we should not take interpolate. I mean, this.
Yes.
We cannot just extrapolate this data or this concept and use that. Okay, do give something which is better than nothing. So that was I intentionally brought it to you, Govind, so that we
Yes,
should not
yes.
think in the same direction. Thank you, Govind.
Correct.
Now I'm coming to Jaya. In NewsFed trial, we have seen that by dual blockade, neoadjuvant is giving a wonderful PCR. So say for some patient, they afforded this neoadjuvant with dual blockade or single blockade, whatever it is, they achieved a PATH CR. Now they are not keen to continue the expensive treatment on adjuvant setup. What will be your take in that situation, Jaya?
So then I would continue with single agent trastuzumab, because even if you look at the affinity, the additional benefit of pertuzumab over and above, of course, trastuzumab alone is very small. So I think I would use only a single drug, that is trastuzumab, in the adjuvant setting. Of course, if this patient has had neoadjuvant chemotherapy and she had locally advanced breast cancer, and then at the end of chemotherapy, she still has residual disease, and if finances are not an issue, then one could consider, change over to TDM1, but that is only if she's received trastuzumab in the neoadjuvant, not where she has received trastuzumab and pertuzumab.
No, Jaya, I am looking at a young lady, an old lady. She could afford only single drug, trastuzumab, and
Yes.
she could finish the neoadjuvant, and it is
Yes.
a PATH CR. Now she
Yes.
is not ready to spend any money in the adjuvant setup. Will you agree? Or you will, or I will pursue, no, you need to give adjuvant because there are some benefit.
What's the initial tumor size?
Say it was a 3 centimeter tumor size, it was a very good biology, and they responded, and it was a PET CR.
Okay, and what was the duration that you gave trastuzumab in the neoadjuvant?
6 months. I have given 6 months.
So, see, I think if we have given 6 months of trastuzumab, I mean, you mean to say you've given 3 months in the neoadjuvant and then 3 more months in the adjuvant? Is
Yes.
that what you're trying to
Yes.
say?
Yes. PET
If
CR
it is
is cheap, and then she had continuous 3 more months. Now said, okay, I don't have money.
No, so in this situation, of course, if she has a low volume disease and she's received total 6 months duration, then I would not insist on her taking more trastuzumab, because as Dr. Sudeep has already mentioned that, the benefit of an additional 6 months of trastuzumab is small. And this lady, as you mentioned, she had a small node negative tumor, hormone positive, and that is probably the subgroup where in the meta-analysis which Dr. Sudeep had published, and also even if you look, this is the same low risk subgroup of the FAIR trial. If you look at the FAIR subgroup analysis, and these are precisely the patients which probably do not benefit from further a year of trastuzumab. So, and if at all, the margin of benefit is very small. Hence, I would not insist on her taking for another 6 months and selling off everything for her.
Thank you, Jaya. I like it. I mean, for me, I mean, yes, 6 months is fine with the low risk group. And if we receive a PET CR, that is a wonderful situation probably, because now we know PET CR is sometimes giving some benefit of survival also in some meta-analysis. So this situation, maybe we can go like that. Okay, now I'm
I
moving.
just
Sorry.
make
Yes, go ahead.
So, and also just like to make one more small comment, which is like, if we have a patient who cannot afford, 1 year of trastuzumab, and she has a locally advanced breast cancer, then giving some trastuzumab, I think, is better than not giving any trastuzumab. So, in fact, for our own locally advanced breast cancers, when we had used something as even as 3 months of trastuzumab, the outcome was better than, of course, that was only as an abstract, but then we saw that the DFS was better than our historical controls of no trastuzumab when we audited it. So I think what is important to know is that if a patient cannot afford, or we know our system, we cannot give trastuzumab to all patients for 1 year, it is better than if we are generating funds or through NGOs to give it for 6 months or 3 months at least to all patients, rather than not give any trastuzumab. So I think now the data is more for 6 months. So at least 6 months of trastuzumab rather than no trastuzumab is what I would say, even if she is locally advanced. definitely if she is a locally advanced ERPR negative, that is a subgroup which might benefit for a year of trastuzumab. But then rather than not give any trastuzumab, I think giving her 6 months would be better.
Thanks, Jaya. Now we are moving. I wish we had more discussion, but we have limitation of time. So the last speaker is Dr. Arman Raza Chaudhary, who is the consultant of radiotherapy in Delta Hospital. He will be talking on PET-CT alone should be the diagnostic tool of choice for metastatic workup for stage 2-3 patient. Is it rational? Dr. Arman Raza Chaudhary.
Thank you. Thank you, Dr. AFM Kamal Uddin, and as well as Oncology Club for giving me the opportunity to present in this prestigious conference. So I'm Dr. Arman Raza Chaudhary, working as a consultant of Department of Oncology and in Delta Hospital. And my topic is PET-CT alone should be the diagnostic tool of choice for metastatic workup for stage 2 and stage 3 breast cancer patients. Is it rational? So at first, I just want to share the use of PET-CT scan in the assessment of multifocality and T staging. There are two papers here. One is published in 2008 in Journal of Nuclear Medicine about the breast cancer staging in a single session, whole body PET-CT mammography. 40 women underwent PET-CT versus DCE MRI, that is dynamic contrast enhanced MRI, and so you can see here that the MRI aided the better quality of T category in 77% of cases, whereas PET-CT in 54% cases, and the difference was statistically significant. Another paper which was published in Radiology Journal in 2011, and here we can see that 380 women who were offered breast conserving surgery underwent DCMRI versus FDG PEM, and MRI had a greater lesion level sensitivity and more accurately defined the need for mastectomy. So in summary, FDG PET-CT scan remains inadequate for accurately define the extent of the tumor relative to the DCE MRI. Now, regarding the axillary lymph node, the detection of axillary lymph node outside the axillary level 1 and level 2, we know that with the axillary lymph node clearance by axillary dissection is usually limited to the level 1 and level 2. So, PET scan suggesting the involvement of the level 3, that is intraclavicular lymph node, as well as extra axillary localizonal node like supraclav and internal mammary, and it gives us the important implications in surgical management as well as the design of the radiotherapy field. And it is the publication in ESMO, by ESMO in Annals of Oncology about the preoperative PET-CT scan in early stage breast cancer. And 103 patients with newly diagnosed operable breast cancer were randomized with tumor size more than 2 centimeters, and the comparison done between the conventional imaging versus the PET-CT scan. And here we can find that the PET-CT scan is a valuable tool for extra axillary lymph node involvement, to see the extra axillary lymph node involvement, to see the distant metastasis as well as the other occult primary cancer. And it has a great impact on the staging and on clinical management. So PET-CT scan could be considered is the initial assessment of the patient with newly diagnosed node positive early stage breast cancer, 2 or more centimeters in size. Now regarding distant metastasis, and here a paper published in Journal of Nuclear Medicine 2013 about the staging workup in comparison with the conventional staging. And here we can see that 117 locally advanced breast cancer patients were taken, and distant metastases were detected by PET-CT scan in 43 patients, while conventional imaging detected metastasis in only 28 patients. And PET-CT scan changed the critical stage in 61 patients, that is about half of the patients. So the accuracy in diagnostic, the bone lesions were 89.7% for bone scanning versus 98.3% by PET-CT scan. Another paper published in Journal of Clinical Oncology in 2008 about the preoperative staging of large primary tumor with PET scan versus conventional imaging. And here also the PET-CT scan changed the initial staging in 42% of the patients. So PET-CT scan showing the higher value of sensitivity and specificity in detecting the distant metastasis compared with the conventional imaging. And so in that paper, PET-CT scan is recommended in large primary breast tumor for preoperative staging. Now regarding the bone scan, regarding the bone metastasis diagnosis, and in this paper, women with suspected metastatic breast cancer evaluated with PET CT scan versus bone scan, and this study supports that the use of PET CT scan in detecting osseous metastasis for suspected metastatic breast cancer. Now, this is the NCCN guideline and the 2020 guideline. Here you can see the red arrow, and the red arrow portion has come on some publications, like these publications in Radiographics in 2007, that PET CT scan is complementary to conventional staging procedure and should not be a replacement of either bone scan or diagnostic CT. And PET CT scan have been shown to be particularly useful in restaging of the breast cancer, to evaluate the response of the therapy, and a problem-solving method when the results of conventional imaging are equivocal. And another paper in 2004 in Journal of Clinical Oncology, they also told that PET CT scan is not routinely recommended for accelerated staging of patients with newly diagnosed breast cancer. So the guideline was from NCCN, use of PET CT scan is not indicated in clinical stage 2 and operable stage 3 breast cancer. FDG PET scan is most helpful in the situation where standard staging studies are equivocal or suspicious, especially in the setting of locally advanced breast cancer or metastatic disease. And PET CT scan may also be helpful in identifying unsuspected regional nodal disease and or distant metastasis when used in addition to the other staging studies. So, conclusion, the same, that is, regarding the diagnostic accuracy, having the considerable impact on patient management and initial staging, PET CT scan can give us some lights, but NCCN describes in a little bit different way. So with the question that what in front of the panelists, that what about the PET CT in locally advanced breast cancer, as well as should we go for PET CT scan in T2N1 or above disease as a staging workup. So thanks for your patience hearing. Thank you all.
Thank you, Arman. So now this is the last topics, and I will try to address Dr. Jatoi left us. So first question is to Dr. Sudeep Gupta. We can understand that it is recommended we can use it as a complement of existing modalities when there is equivocal situation. So say in Tata Memorial Hospital, it is quite reasonable cost, PET CT. So why to do multiple modality imaging? Why not when there is a locally advanced or a stage 3 disease, clean cut, go to PET CT rather than doing a CT if there is equivocal, go to PET CT. Your comment, please.
So my own suggestion is that I strongly advise against performing PET CT in these patients, even if it is cheap and even if it is available. And I never advise and I never want to get it there as the first modality. And I will tell you why. There are many patients who are wrongly labeled as having metastatic disease based on equivocal findings of PET CT. And every week I see at least 10 patients in the OPD whose PET CT has been requested by other physicians, who come with small equivocal findings either in the lungs or in the mediastinal lymph nodes or elsewhere, which cannot be biopsied. And they were going to go ahead and get treated with curative intent, and now everybody is scratching their heads as to whether they have metastatic disease or they have localized disease. And let me tell you, there is something called the Will Rogers phenomenon, also called the stage migration. If you just keep shifting patients between two stages of a particular disease, you will apparently improve the outcome of both stages, but this is an apparent improvement, not a real improvement. And in my own experience, PET CT has the potential to confuse physicians as well as patients far more than it is useful. And I completely agree with those guidelines that it should only be used when you need to clarify something on conventional imaging and not as the diagnostic modality of first choice. Of course, I am beginning to go into a minority. The nuclear medicine physicians are very aggressive. Everybody wants to get a PET CT. But again, let me say, I will strongly advise against getting PET CT as a first modality, even if it is very cheap.
Thank you very much. So as you mentioned, I believe that PET CT take away the sleep of both the doctor and the patient. Dr. Govind Babu, even after all one small single metastasis picked up by PET CT can change doctor's story. Why not you still go for PET CT if you are not a believer? Or if you're a believer, you can go for that.
Yeah, no, I totally agree with Dr. Sudeep. As of now, it's confusing, creating more confusion. But the unfortunate thing is, many of these patients, even before they reach an oncologist, they have a PET CT done and they come with that. So that is the unfortunate thing.
So what is your comment? Say surgery is done, then PET CT is done, then patient is referred to oncologist. I mean, we are getting this type of experience. Do you want to make some comment on that? Because if somebody is really doing to keen a surgery, because the surgery is done, no hard feeling with the surgeon colleagues. Patient, they may be provocated. After surgery, they want to check if there is any more tumor in the body and they want to do it. And they come back with some illuminating area.
Yeah. Yeah, that is a sad thing. If at all they want to do it, they should do it before surgery. I would not recommend it at all. Like all the guidelines say, it's only in those situations where you need to clarify a point. The conventional imaging is the ideal thing. And again, these PET CTs pick up so many things. And like Sudeep said, many times we are not able to biopsy it. So that is an unfortunate situation.
What is your comment after how many weeks minimum of any surgery a PET CT should be done?
I will never ask for a PET CT after surgery.
Okay. Okay. So now I want to go to Dr. Giles. So a PET CT is done, but PET CT said axillary node. There is no axillary node, but we know PET CT is not very fantastic tool for axillary nodal evaluation. So for any reason, PET CT was done. So will you be going for additional imaging to exclude the node, or you will go for proceed with your treatment?
No, I mean, so we, unlike others, really, we don't use PET CT routinely. We use them for problem areas. So, and we use, if we want to look at the axillary in detail, we would use axillary ultrasound, which is controversial anyway. The Americans we know don't tend to do that because they're worried about over treatment of the axilla. But we do an axillary ultrasound if there's a question about that.
So
yeah.
That is the take that you see. Even PET CT is a great imaging, but it is not great for every site and every location. So in breast, axilla is very important for our imaging, where mammogram or ultrasonogram is giving us a wonderful information. Even when we're doing the staging CT scan, it is giving information. Unfortunately, PET CT is not giving a great information. So moving to John. So John, will you be a believer of PET CT? Because in the era of oligometastasis, PET CT can pick up oligometastasis. So will you be a believer?
Yeah, so if the PET CT has suggested something that's accessible, then I always believe biopsy, what's FDG area to confirm. A good example, of course, is if you see mediastinal lymph nodes, I'd organise for EBUS to get tissue confirmation that there's distant disease if feasible. So I wouldn't just believe the pictures, I'd try and obtain tissue to be confirmatory.
Thanks. So the message is that even PET CT is illuminating very bright. The SUV, somebody said stupid uptake value is very high. Biopsy is the hallmark. Only PET CT cannot provocate us for any treatment. So last point to Jaya. So what is your comment about the high false positivity of bone metastasis in PET CT? Because say we always do technetium bone scan, but we have experienced that with PET CT, we have seen there are illuminating bone, but finally we found it is not a metastasis. So it sometimes take away our sleep. So any comment on that, Jaya? False positivity or high positivity? Yeah.
So false positivity of PET CT. So in our setup, we see in two situations apart from bone. One is the lungs. If patient has had a previous history of tuberculosis, many a times, or even an active tuberculosis, they are picked up as, they light up very nicely on the PET CT. And unless and until we biopsy, many a times we found that there was a single lung nodule or a mediastinal node, which later came out to be granulomatous. So that is one common situation that we face. And as you rightly mentioned, some of these benign bone diseases also light up on PET CT. So if there is no clinical, and that becomes very difficult to distinguish, especially also if we are not able to biopsy. But I think the more common problem that we have faced is not the bone, but it is these lung nodules which light up and which are of infectivity rather than being metastatic.
Thanks, Joya. So we are almost at the end of the panel discussion. So before COVID, this structure in Chicago was busy. Now it is blank. But COVID is not always done some harm. So today we are meeting each other so easily because of COVID. So this is everything has every coin has both the sides. So this is the other side of the coin. And finally, I want to finish with the great man, Bernard Fisher, who is the great surgeon and who is known for his contribution to breast cancer. He said, in God we believe, all other must have evidence. But with all my due respect to Bernard Fisher, today in the era of 2020, we land in some situation where we don't have enough evidence, but we need to face the situation. And there we need to find a logical solution. So that was the objective of our today's total panel discussion. I hope our all the panel members had good time, good fun. Thanks to all my panel members from UK, from America to India, everybody. And thanks to all my 5 presenters who are our, I will say they're upcoming, they're the future oncology, the leader of our oncology in our country for their wonderful presentation. And I tried to make the link between them and you. And we tried to give some message to our audiences. Hopefully we have done it. And finally, I want to thank, I was requested to give a special thanks to, personal thanks to all our foreign faculties who helped us to grow our level of knowledge by exchanging views with them. And we are so grateful to them because people like Sudeep, people like Govind Babu, John, Giles, they are so busy, smart. We are so grateful that you gave us time and we could share our experiences. Thank you very much. And we had a wonderful discussion and I'm sure our audience enjoyed it. So now we end the session. Thank you very much.